Welcome to a crash course in pediatrics. My name is Dr. Shahid. I'm a general pediatrician and medical educator. CRASH stands for Clinical Reasoning and Analytical Skills with Shahid. The goal of this course is to teach clinical reasoning skills to medical students and residents. This is a series of lectures that will take you through several pediatric cases where you will learn how to critically think through a patient case and come up with a broad differential diagnosis. These cases are intended for educational purposes only and are not intended for actual patient care. The objectives of the CRASH course are listed here. So let's start our case. So in this case, we have an 18-month-old female who presents to the emergency department with episode of coughing up blood. Mom says patient has been coughing for the past 2 days, and today Mom noticed blood in her mucus. She was having a coughing fit and then spit up mucus that had blood in it. She has had a runny nose and congestion as well, but no fevers. She had one episode of vomiting after a coughing episode yesterday. Past medical history: patient has had several episodes of wheezing requiring albuterol neb treatments and steroids in the past 6 months. She was hospitalized last month for a pneumonia. Immunizations are up to date, and there are no known drug allergies. Birth history was normal. Diet: patient was switched to soy formula for colic and diarrhea at 3 weeks of age. She is now on whole milk and table food. Social history: she lives with a mother and father, an 8-year-old sister, and a 5-year-old brother. Family history: dad has seasonal allergies, and the sister has eczema. On physical exam, temperature is 37.2 Celsius, heart rate of 110, respiratory rate of 34, blood pressure of 98/64, and 92% on room air. Weight is in the 25th percentile. She was at the 50th percentile 4 months ago. Her height is still at the 50th percentile. In general, she has mild respiratory distress. Skin exam reveals no rashes. HDNT is normal. Lung exam: there are diffuse wheezing bilaterally. There are some crackles that are heard in the right lung, with mild subcostal retractions bilaterally. Cardiac exam is normal. Abdomen exam is normal. Back is normal. GU is normal. Extremities are normal. And neural exam is normal. So our problem list is an 18-month-old female who comes in with hemoptysis. She has a chest x-ray that revealed a right middle lobe infiltrate. She's had a history of recurrent wheezing episodes and some poor weight gain now. So in this case, we have an 18-month-old female coming in with hemoptysis. The history is that she's been coughing for the last 2 days, and now mom has noticed some blood in the mucus. So let's go through the differential diagnosis of an 18-month-old with hemoptysis. First of all, hemoptysis is not very common in the pediatric population. So when you see hemoptysis, there's things you have to think about, but it's not something that we commonly see in pediatric patients. The other thing to consider is when you have the history of the patient coughing up blood. In pediatrics, it's important to determine if that is actually blood in the mucus and coming from the lungs, or is it actually hematemesis and blood coming up from vomiting. So it's important to differentiate between hemoptysis versus hematemesis, and sometimes it can be difficult to differentiate that, and hematemesis is potentially much more common than hemoptysis in pediatrics. And they have two very different differential diagnoses then. But in this patient, based on the history, it seems to be that it was more coughing and mucus, and it was more coming from the lungs, so like the hemoptysis. Although the history is that she had an episode of vomiting after a coughing episode, but there was no history that there was any blood mixed in with the emesis. So this patient likely has hemoptysis, and we're going to go through the differential diagnosis of hemoptysis. There's different type of processes that you have to think of. The initial thoughts are going to be related to infection, some sort of pulmonary infection. Given her history, a big consideration is going to be pertussis given the fact that she is having these fits of coughing, again by history she has fits of coughing, and then she had this post-tussive emesis along the way as well. So those are some things that you would see with pertussis, would be fits of coughing, and then you'll have potentially post-tussive emesis, and then sometimes you might have post-tussive cyanosis or post-tussive apnea. So she has a couple of those things to consider. So pertussis is definitely on the differential diagnosis for this patient, and then sometimes that can actually present with hemoptysis as well, but related to the pulmonary infection. Other type of infections are going to be basically pneumonias, so different causes of pneumonia can cause you to have hemoptysis as well. Common organisms, sometimes viruses can sometimes do that as well, but a lot of times bacterial pneumonias will more likely give you hemoptysis and coughing up blood in the mucus. So things like group A strep, pneumococcus, Staph aureus, those are all causes of bacterial pneumonia that you have to potentially consider. And then sometimes it can start with a viral process and then go on and develop a secondary bacterial pneumonia as well then. So like I mentioned, you have different viruses, you can have different bacterial causes of pneumonia, and then TB, again, not that common in pediatrics, depending on if they're in an endemic area, if there's a travel history, or exposure in the family, or other risk factors. You think about TB, again, also depending on travel history. A fungal infection, so different parts of the U.S. There's endemic fungal infections that you got to think about, like histoplasmosis, coccidioidomycosis, so different type of fungal infections that can cause pneumonia that you have to think about as well. And then you can have a complication of a pneumonia where you just start off as a pneumonia, but now you develop an empyema or an abscess, right? So you actually develop some sort of abscess or empyema. And that can cause a more severe pneumonia and lung infection, and then you can have hemoptysis as a result of that as well. Okay, and then other things that can give you hemoptysis, more chronic type of processes and infection and inflammation of the lungs. We can kind of maybe bunch those under bronchiectasis. So anything that can cause bronchiectasis, which is basically chronic inflammation of the bronchi, of the airways of the lung, can cause you to have hemoptysis as well. So chronic infection, chronic inflammation of the lungs, and when you have an underlying cause of it, then that can set you up for hemoptysis. So some of the common things that you think about for bronchiectasis would be things like cystic fibrosis. Other things you might think about would be like ciliary dyskinesia. So ciliary dyskinesia can cause it as well. And then other immunodeficiencies, so any type of immunodeficiency giving you chronic pneumonias and pulmonary infections, and then other type of things that can give you bronchiectasis include ABPA, which is allergic bronchopulmonary aspergillosis. So it's a hypersensitivity pneumonitis to aspergillus, which is a common fungus that is around. So it's not an actual fungal pneumonia, but it's more of a hypersensitivity response and pneumonitis to the aspergillus. So that can give you bronchiectasis as well, and that can give you hemoptysis. So anything that gives you bronchiectasis and the differential bronchiectasis, there's a few other things to consider, but these are probably the more common things that you consider. So I mentioned the hypersensitivity pneumonitis that can cause you to have hemoptysis as well. So hypersensitivity pneumonitis. So again, that could be from, as I mentioned, the allergic bronchopulmonary aspergillosis. It could relate to that. And then it could also be related to milk protein allergy. So there's an entity that gives you kind of a hypersensitivity pneumonitis and then can present with pulmonary hemorrhage or pulmonary hemosidrosis that is associated with a milk protein allergy. And that is called Heiner syndrome. So that's another entity to consider as well. So Heiner syndrome is basically kind of a hypersensitivity pneumonitis related to an allergy and hypersensitivity to cow's milk protein, and they present with pulmonary hemorrhage and pulmonary hemosidrosis with the history of the cow's milk protein allergy, and they potentially would have this entity of Heiner syndrome. And there's other kind of pneumonitis, or more kind of, I guess, more immunologic based or vasculitic type of processes that you think about, right? So there could be different causes of vasculitis that can present with with hemoptysis as well. So things like HSP, lupus, JIA. So different type of vasculitis or autoimmune type of processes as well. A couple other autoimmune type of entities that you might consider would be things like let's see, we can write it here. So one would be the old name is called Wegener's, right? Wegener's granulomatosis, right? But now it's actually changed its name. It's called it's abbreviated now GPA, which is granulomatosis with polyangiitis. So that's a new name for Wegener's granulomatosis. So it's basically a vascular process that can present with pulmonary hemorrhage and hemoptysis as well. So now the new name is GPA granulomatosis with polyangiitis. Then another vasculitic or autoimmune process would be Goodpaster's disease, right? So most of us are familiar with that, where they can present with renal involvement, right? They can come in with hematuria and renal involvement, also with pulmonary hemorrhage. So Goodpaster's as well as a kind of autoimmune or vasculitic type of process that can give you hemoptysis as well. Okay. Other things then to consider on the differential would include things that can give you chronic aspiration, right? So if you have pneumonia, you can have an acute pneumonia, or you can have more chronic pneumonias or chronic aspiration. So sometimes you can have neuromuscular issues and cerebral palsy or other causes of chronic aspiration, and you get the recurrent pneumonias or even bronchiectasis, and that can give you hemoptysis as well. Or you can have something anatomical, like a TE fistula. So a TE fistula putting you at risk for chronic aspiration, something to potentially consider as well then. Other things, you can have other type of bleeding disorders, where you bleed into the lungs because you have some sort of bleeding disorder possibly as well, or you have some sort of AV malformation, so an AVM, or some sort of hemangioma, so a vascular type of process that can cause you to have bleeding into your lung and hemoptysis, so an AVM or hemangioma that ruptures or bleeds can give you hemoptysis as well. In other things, you can have trauma, so you can have like a pulmonary contusion. So in pediatrics, you always worry about accidental trauma and non-accidental trauma and abuse and some sort of pulmonary contusion presented with hemoptysis. In pediatrics, it's very uncommon, but a pulmonary embolism could be considered, but that would be if they have some sort of underlying hypercoagulable state causing them to have pulmonary embolism. Say they have sickle cell disease, or they have protein C or protein S deficiency, or factor V Leiden deficiency, or something that gives them a hypercoagulable state for which they get a pulmonary embolism then. And sometimes if you have severe pulmonary edema from like heart failure, that can do it as well, secondary like CHF and heart failure. That can give you potential hemoptysis in kids as well. And then maybe a couple other things to consider, kind of anatomical type of things. One would be a pulmonary sequestration. So pulmonary sequestration. So this basically is lung tissue that has blood supply from the pulmonary artery, but does not have lung supply from the aorta or an arterial blood supply. So pulmonary sequestration is lung tissue that is not very it's very effective at ventilating, because it basically has a pulmonary blood supply but does not have an arterial blood supply. So that causes ischemia, and then the tissue dies off and is not effective for ventilation then. So a pulmonary sequestration then can cause hemoptysis, because that area of the lung becomes ischemic and dies off, and then presents with hemoptysis. Then the last entity I want to mention is called something called right middle lobe syndrome. So right middle lobe syndrome basically is a chronic and recurrent infection of the right middle lobe. And it's basically due to some sort of anatomical defect of the bronchus going to the right middle lobe. So because of that, because the bronchus is either narrowed or strictured, or the angle is a little bit abnormal, or something causes that bronchus to be abnormal anatomically, and that causes mucus plugging and atelectasis chronically of the right middle lobe. So when this patient presented to the emergency room, a basic workup was done. She had a CBC and a CMP, just to get some basic profiles. And then she also had a sweat test and immunoglobulins done initially as well. And that was because there was some concern about some chronicity to this, given the fact that she had lost some weight and had some poor weight gain recently, had recurrent episodes of wheezing requiring albuterol and steroids and a pneumonia in the past. So there was some concern that this could be something acute on chronic. So I had a little bit of workup from that perspective. So the CBC essentially came back normal. Her white count was a little bit elevated, and did have a little bit of elevation of her eosinophils. Her eosinophil percentage was about 7.5%. Usually it should be less than maybe 5% or even 3%. So she had a little bit of elevated eosinophils on the CBC. The rest of the CBC was normal. Her complete metabolic panel was normal. Her sweat test came back negative to help rule out cystic fibrosis. And her immunoglobulins, everything was normal. Her IgG, IgM, IgA was normal, but her IgE level was a little bit elevated. Not super high, but just a little bit elevated. So she had a little eosinophilia and a little elevation of her IgE as part of the initial workup. And then she had a pulmonary consult, and they recommended a bronchoscopy to try to get a better look and see what might be happening, causing this hemoptysis. And on the bronchoalveolar lavage, she had iron-laden macrophages. So some concern about some hemorrhage there. So she actually ended up having an open lung biopsy of the right middle lobe, where she had the infiltrate on X-ray, and the open lung biopsy showed alveolar hemorrhage and hemosiderosis without any fibrotic changes or vasculitis. And then there was cultures that were done to look for different infectious causes, and those were all negative. So at this point then, to kind of summarize where we're at right now, to reassess and reevaluate what we think is going on, is now we have this 18-month-old coming in with hemoptysis, but it's found to have pulmonary hemosiderosis on bronchoscopy and open lung biopsy. She has this history of recurrent respiratory symptoms and infiltrates, and also some poor weight gain, some eosinophilia, elevated IgE level, and then had this history in the past of needing to be on soy formula as a baby, because at around 3 weeks of age she had a lot of diarrhea and was really colicky, so was actually switched to soy formula. And then at 1 year of age she was switched back to whole milk and cow's milk formula. So based on these constellation of findings, the diagnosis of Heiner syndrome was suspected, given her history, given the labs, and given the history of the milk protein intolerance potentially, and some of her pulmonary findings. So a diagnosis of Heiner syndrome was made on her based on all of those findings. Then, so again, Heiner syndrome is basically a hypersensitivity to cow's milk protein and causes pulmonary disease as a result of being exposed to cow's milk. Then, so it's very rare, not that common at all, but can present in this age group with hemoptysis. So typically, what you would see is these recurrent lower respiratory symptoms of pneumonias, then poor weight gain and failure to thrive, and you might also see some eosinophilia on the CBC, and maybe even iron deficiency anemia from chronic blood loss into the lungs, and then you would see some pulmonary hemosiderosis on bronchoscopy or open lung biopsy. So based on all that, she was given this clinical diagnosis of Heiner syndrome. So basically, nobody understands the mechanism of it, but it's some sort of immunologic response to cow's milk protein, and the intolerance that they have in the GI tract, but further causes some sort of immunologic response in the lungs as well, causing you to have the hemoptysis and the inflammation in the lungs. Then, so sometimes IgE levels might be elevated in patients as well as a response to kind of an allergic reaction or allergic process. As was seen in our patient as well. Then, so basically, the treatment that basically is going to be avoiding cow's milk protein, and then given different types of protein, which she was on soy protein, soy milk earlier on, and when she was switched over to whole milk, that's when she started to have, in those 6 months, chronic respiratory symptoms and pneumonias and wheezing and things. So putting them on soy protein or some sort of hydrolyzed elemental type of milk and formula can help with the hypersensitivity response. And then symptomatically, you can treat with bronchodilators, sometimes even steroids, oral steroids or inhaled steroids to help reduce inflammation can help, or other immunosuppressants might be needed in those patients as well. Then, so this patient again turned out to have Heiner syndrome, not very common, but can present in this age group with hemoptysis. So again, to recap, so we had our 18-month-old female coming in with hemoptysis, kind of a broad differential. You think about pertussis, given some of the symptoms that she was having, but also other pneumonias and other infections causing hemoptysis. This by far is the most common category and cause of hemoptysis. And then if they have any chronic recurrent respiratory findings, or they have clubbing on exam, or they have poor weight gain and failure to thrive, then you start to think about some of the more chronic type of things like bronchiectasis and other underlying factors, or chronic aspiration and things as well. And then you think about vasculitic processes or hypersensitivity type of responses, and then other bleeding issues that you might think about as well. And then always think about the anatomical things, which a CT of the chest can sometimes help rule out some of these findings of the pulmonary sequestration or right middle lobe syndrome, or other type of anatomical type of processes as well. So again, this is an overview of hemoptysis as part of our CRASH case. And again, the goal of the CRASH case is not to teach about each one of these entities, but to give an overview about the presentation and how you might approach it, and the differential diagnosis. Now you can go back and maybe read up on a few of these things and specific entities, and read more about them and read more about Heiner syndrome. And again, the focus is more on kind of reasoning through the patient and coming up with a broad differential diagnosis. So hopefully this CRASH case was helpful and beneficial and educational, and we look forward to seeing you at future CRASH cases as well.